Hi, I'm Chris Carpenter from Washington University in St. Louis. On behalf of the Geriatric Emergency Care Applied Research Network Cognitive Impairment Group and my co-authors, thank you to the Society for Academic Emergency Medicine for the opportunity to present this research. We have no commercial conflicts of interest to report, but this research was funded by the National Institute of Aging. Older adult cognitive impairment, both delirium and dementia, are often unrecognized in ED settings. SAEM's GED guidelines emphasize dementia and delirium screening and appropriate delirium prevention, despite a paucity of ED-based research. Prioritizing the highest yield ED-based cognitive impairment research is therefore vital. Undoubtedly, there's significant overlap between dementia and delirium in the ED patients we see with cognitive impairment. The patient with dementia, whether that's diagnosed or not, is a vulnerable brain that's more susceptible to incident delirium, prevalent delirium, and the episode of delirium that occurs may be both more severe and of longer duration, and it may negatively impact the natural course of that baseline dementia. The GEAR Network is an NIA-funded transdisciplinary healthcare team including geriatricians, emergency medicine physicians and nurses, social work, pharmacists, and patient advocates, over 50 in total. And over a one-year period, we did a scope and review of the literature in the areas of cognitive impairment, medication safety, fall prevention, elder abuse, and transitions of care before traveling to ACEP 19 in Denver and spending a day and a half before ACEP 19, prioritizing the highest yield research areas for each of those 5 domains. The Cognitive Impairment Group's objective was to synthesize the state of the science for ED detection and management of cognitive dysfunction in older adults, and subsequently to attain consensus at that ACEP 19 pre-conference. The methods that we used were to identify stakeholders about a year before the consensus conference. With that, those stakeholders developed PICO questions. PICO questions are populations, interventions, comparisons, and outcomes. And then use those PICO questions, the top 2 PICO questions, we developed more than 2, but we voted on the top 2, to develop a scoping review with the assistance of a medical librarian, what is already known for each of those 2 PICO questions. And then with that scoping review, develop high yield research questions that we then brought to the consensus conference for voting in October 2019. The first PICO question that we voted to tackle was delirium detection, the accuracy of Gestalt or using an instrument to identify delirium in ED settings. This has to all be ED-based research. The second PICO question dealt with intervention on delirium, prevention of delirium, or treatment of delirium. You'll see the second PICO question only had 15 studies, and only one of those was a randomized controlled trial. PICO question number 1 identified 27 different instruments, and that included nurse or physician Gestalt. A very heterogeneous population was studied across those studies, as represented by delirium prevalence ranging from 6% to 38%, and multiple gold standards were used to validate whether delirium was present or absent. PICO question number 2, like I said, only had 15 studies, 1 randomized controlled trial. They evaluated very dissimilar interventions ranging from staff education to pain management protocols to pharmacologic strategies, and used a one-size-fits-all approach. There is no consistent criterion standard for the diagnosis of ED delirium, nor any consistency in the outcomes assessed or the timeframes over which those outcomes were assessed. So what were the questions that we brought to the consensus conference in Denver? Well, these are the 8 questions you're going to see. And number 1, the one that ended up being voted number 1 by the consensus conference, was delirium prevention, including development of a risk score that doesn't depend on any extra work from the nurse or physician, either using electronic medical records, smart logic, or some process that takes the nurse or physician out of the equation. Number 2 was evaluating ED delirium prevention strategies, the effectiveness of those strategies. The rest of the 6, 7, and 8 you can see here. One that we had been particularly excited about from the cognitive impairment group was identifying ED delirium phenotypes, which we'll talk about more in just a minute, and then phenotype guided targeting of delirium prevention or strategy. As far as the diagnostic hierarchy of delirium screening instruments, the lowest tier of evidence is accuracy, sensitivity, and specificity. Can we distinguish delirium present or delirium absent with these screening tools? Higher levels of evidence get to, can we identify a subset of patients now with delirium that we weren't identifying before? And then even higher than that, can that new subset we identify be intervened upon in a way that we can positively improve outcomes? As far as the idea of delirium phenotypes, mechanistically, we do not understand what biological process is operating in the case of hypoactive delirium or hyperactive delirium, and we therefore use a one-size-fits-all approach to treat every type of delirium with these interventions that we study. But we don't know, because we don't mechanistically differentiate them or understand the underlying process, whether an intervention doesn't work because we used it on the wrong etiology of delirium or the wrong subtype of delirium. I think we have a long ways to go to understand better the mechanistic approach to delirium intervention. In addition, the science of implementation science has really not been used. No studies have yet evaluated essential implementation science attributes such as fidelity, adaptability, sustainability, or pragmatic application of delirium interventions in emergent department settings. As far as the delirium interventions go, there were only 15 studies identified, among those one RCT, which could be argued we shouldn't be doing much of anything for delirium interventions in ED, but we would argue that the absence of evidence is not evidence of absence, and we just need to keep looking for effective treatments for delirium in ED settings. So our consensus conference voting was obviously limited by a few eligible studies, and the panel itself may not have been representative of all of geriatric emergency care. But in conclusion, there are multiple screening instruments available. Available intervention research does not really guide ED delirium prevention or treatment at this point, and GEAR prioritized delirium prevention as the highest research priority. Thank you.